Hi, I'm Conrad Fisher, and welcome back to our next section, which is lung infections. Of all of the captains of the men of death, pneumonia, lung infection, is the chief. In fact, pneumonia is the only one of the top 10 causes of death in the United States that is an infection. Worldwide, 9 out of the top 10 causes of death in the world are infections. But it is only pneumonia at number 6, just above suicide, which is in the top 10 cause for an infection. Now, lung infections come out with people who have fever, cough, and sputum. Now, fever, cough, and sputum is rather nonspecific for a lung infection. Fever, cough, and sputum, fever, cough, and sputum. But fever, cough, and sputum, that could be a bronchitis. Fever, cough, and sputum, fever, cough, and sputum, fever, cough, and sputum. Why, I could be obsessing. Fever, cough, and sputum, fever, cough, and sputum. Fever, cough, and sputum could be a pneumonia. Fever, cough, and sputum. Well, then how do I tell whether the person has bronchitis, sinusitis, or otitis? Why, all of those can give you a person who has some degree of fever and cough, whether it is bronchitis, pneumonia, or a lung abscess. Well, we're going to tell you how you're going to tell it's bronchitis. Bronchitis is much milder. Bronchitis gives you just a little fever. You see that little fever? Look at the abscess here. Look at the abscess that has a big fever. Look at the abscess here that has a big fever. Look at the abscess here that has a big fever. Bronchitis has a little fever. Abscess has a big fever. Bronchitis, look at this. Bronchitis is going to be a person who has a chest x-ray that is normal. Okay, bronchitis, mild, little fever, normal chest x-ray. Mild, little fever, normal chest x-ray. Mild, little fever, normal chest x-ray. Well, what a coincidence. Are those the same antibiotics from the person who had sinusitis and otitis? Huh, what a coinky-dinky. Turns out that the same antibiotics that can be used for bronchitis and sinusitis, otitis, are all the same because the number one organism is strep pneumonia. Oh, mild disease, little cough, fever, negative chest x-ray, bronchitis. Abscess, we've got a big fever. Abscess, we've got a chest x-ray with an air fluid level. We've got an abscess with a chest x-ray with an air fluid level. An abscess with an air fluid level. Got an abscess with an air fluid level in it. Okay, so now you can have air fluid levels with tuberculosis. How are we going to tell this apart from, let's say, tuberculosis? That gives a big fever, that gives a cavity, that gives a cavity, that gives a cavity, that gives an air fluid level. How are we going to tell that apart from a person who's got tuberculosis? And the answer is that the same way that TB falls into a particular group, TB falls into that group of people who are recent immigrants, healthcare workers, homeless, people who are immigrant, healthcare, homeless, alcoholic, immigrant, healthcare workers who are prisoners. Abscess almost exclusively falls into the group of people who have a combination of two things. Bad teeth, the combination of two things. People who have bad teeth and people who have some increased risk of aspiration. They have a seizure. They were intubated. They have a seizure. They were intubated. They have a seizure. They were intubated. They are people who are alcoholic, intoxicated, seizing people with bad teeth. You know, normal people don't get lung abscesses. You aspirate all the time, but you don't get a lung abscess for two reasons. Number one, what you aspirate is in very tiny amounts. Then you cough it up. Look, right? I aspirate. Cough it up. It's in small amounts, and it's not infected. People who get lung abscesses are people who have bad teeth. They got all sorts of creepy, nasty critters crawling around their teeth and their gums. Then you get intubated, seizures, stroke, intoxicated. Intubated, seizures, stroke, intoxicated. Lions and tigers and bears, oh my! Intubated, seizures, stroke, intoxicated. drank myself blind drunk, fell down and aspirated, had a seizure, aspirated, had a stroke, lost my gag reflex, aspirated, got a little help from endotracheal intubation, aspirated, seizures, stroke, intoxicated, bad teeth, aspirated, high volume, infected materials. Now the other thing is that bronchitis, mild, small fever, negative chest x-ray, short duration of symptoms. Abscesses, long duration, weeks and weeks, if not months of symptoms. Because you need time to develop an obsession, you know. You need time to start obsessing. Ready? Today I have a seizure, a stroke, intubated, intoxication, I aspirate. Then I get a chemical pneumonitis and a chemical burn, which turns into a pneumonia, which turns into a cavity, and that takes weeks. That takes weeks. What is the single most accurate diagnostic test for a lung abscess? Can't be an X-ray. Can't be a chest CT. Can't be an MRI. The single most accurate test for a lung abscess is a biopsy. But what about the sputum, man? Why don't you culture the sputum? Because culturing the sputum doesn't tell me what's inside the lungs. Everybody's got anaerobes in their sputum. Even nice girls have anaerobes in their sputum. Everybody's got anaerobes in their sputum. The same way you've got Gardnerella in your vagina, I have anaerobes in my mouth. So we can't culture sputum for anaerobes because everybody's got anaerobes in their sputum. You need to know if they're in the lung. A biopsy is the most accurate. So you're saying you do a biopsy? No one ever said that. I never said I do it, but it is the most accurate. The therapy for an abscess is penicillin or clindamycin. Penicillin is for above the diaphragm anaerobes. Penicillin or clindamycin for above the diaphragm or respiratory anaerobes. Penicillin for above the diaphragm or respiratory anaerobes. Penicillin is for above the diaphragm or respiratory anaerobes. Penicillin and clindamycin. Penicillin or clindamycin. Metronidazole for gut anaerobes. Metronidazole for the bowel. Clinda for the anaerobic strep that's in sputum. Now remember, the difference in the lung infection called a lung abscess is it has to be a particular person who's got bad teeth, who aspirated in high volumes. A seizure, a stroke, intubated, some loss of gag reflex, high volume, bad teeth. You don't want an abscess? Remove all your teeth. No problem, remove all your teeth. You will not get an abscess because you can't have infected material. Chest x-ray shows a cavity. What's different about this cavity from tuberculosis? The single most characteristic thing about an abscess on physical finding. What is the single most characteristic thing on abscess of physical finding different from all the other diseases? And the answer is, it is the only one that smells bad. Smells bad. The smell of the abscess is the single most characteristic thing about this from other respiratory infections. And the reason is that your body is rotting away. Rotting body parts. Ooh, that's creepy. You aspirate, you get a chemical pneumonitis. It causes you to have a pneumonia. Over several weeks, it cavitates. And then, hey, left lower lobe. You know how it would be like if you left a piece of fish or a piece of meat out in the kitchen for 2 days and you came back and you walk in the door and you go, what is that rotty smell? What is that dead animal that left out to rot here? Well, that's what you smell in a lung abscess. You smell dead, rotten body parts in a lung abscess. Dead, rotten body parts in that lung abscess. Oh my God. Disgusting. Disgusting. Clindamycin. Smells bad. Biopsy the most accurate. Now, what's the difference between that and someone who has a pneumonia? Well, what is different about this from a person who has a pneumonia is that the single most important thing about pneumonia is in fact not the organism. Is it true that for the general population, if you have community-acquired pneumonia, bad enough to lead to hospitalization, the most common cause is strep pneumonia? If you're young and healthy, although you may have a lot of mycoplasma, mycoplasma is not bad enough to mean you get admitted. However, if you have a bad enough pneumonia, even a young and healthy person, strep pneumonia. Young person admitted with community-acquired pneumonia, strep pneumonia. Old person admitted with community-acquired pneumonia, strep pneumonia. Old person with COPD, strep pneumonia. Old person with diabetes. What's the most common cause of community-acquired pneumonia? Let me hear it. Come on, come on. It is strep pneumonia. How about this one? What's the most common cause of community-acquired pneumonia in HIV? Strep pneumonia. What's the most common cause of community-acquired pneumonia in an alcoholic? Am I boring? Am I repetitious? Do you find me annoying? What's the most common cause of community-acquired pneumonia in an alcoholic? Maybe you want to say Klebsiella. Maybe you want to say Strepsiella. But it's not. It's strep pneumonia. When Klebsiella pneumonia occurs, it occurs in an alcoholic. But the most common cause of community-acquired pneumonia in an alcoholic is strep pneumonia. When Staph aureus pneumonia occurs, it occurs in someone who had a recent viral infection. But the most common cause in viral infections is strep pneumonia. Whatever group it is, the most common cause of community-acquired pneumonia is strep pneumonia. The most important thing about community-acquired pneumonia is not the organism at the beginning. Did you know that if you take cultures of sputum, stains of sputum, if you culture sputum, torture sputum, stain it, and make it tell you all of its secrets, you still don't get a diagnosis off the sputum in 30 to 50% of patients? The second thing is this. What's the most accurate test for strep pneumonia? It is a culture. But you don't have the results of culture, do you? At the time, you need to make the decision, treat, don't treat. So the fundamental issue about pneumonia is in fact not the organism. It's, do you know who should be admitted? Do you know what it is to have mild pneumonia that can be treated as an outpatient, or severe pneumonia that can be treated as an that has to be treated as an inpatient? And it's not the organism. Fever, cough, and sputum. Fever, cough, and sputum. Now, this happens to be Dr. Fisher's 15th year of teaching board review for Step 2 USMLE. Oh my God, let's cut them in half and count the number of rings. No, let's get a sample and do DNA sampling for carbon-14 decay. Look, is it the Shroud of Turin? Oh no, it's Conrad Fisher. Well, 15 years ago, we used to make a big deal about what's the color of the sputum. It was like a wine tasting menu. Yellow meant this and green meant that, and you know what? We were totally wrong. Totally wrong. Totally wrong. Totally wrong. Okay? When I was 27, it was the first year I did these classes, 27 in this, sputum colors, irrelevant. Irrelevant. The organism, irrelevant. You don't have it. But back then we were also saying that beta blockers killed you in congestive failure. We also know now they decrease your mortality. What it turns out is we're just not very good at being able to tell the etiology of pneumonia by cough, by sputum, by physical findings. It turns out that we're terrible at it. It turns out that the only thing we could do is tell who's severe. It turns out it's the only thing that matters. Because outpatient pneumonia, oh, look at this, outpatient pneumonia, look at the treatment. Macrolides, fluoroquinolones. Macrolides, fluoroquinolones. Macrolides, fluoroquinolones. Turns out that the treatment is macrolides and fluoroquinolones. One of these for outpatient pneumonia. For inpatient pneumonia, it's similar to that. For inpatient pneumonia, it's similar to that, except what you do for inpatient pneumonia is you add ceftriaxone or cefotaxime and a macrolide, which is azithrochlorithro, or you use a quinolone alone. Levo-gatimoxy, levofloxacin, gatifloxacin, moxifloxacin. So the biggest issue is, how do you determine who needs to be admitted? Well, the question comes down to, do you know what it means to have a severe pneumonia? What does severe mean to you? Well, what do lungs do? Lungs, I heard, you know, when I was in medical school, we needed the lungs to have us breathe. And if you couldn't have lungs that were working, you had hypoxia, you had shortness of breath, you had respiratory distress, you had shortness of breath, respiratory distress, dyspnea on exertion, hypoxia. If you have severe pneumonia, you have hypotension, you have an increased pulse and you're tachycardic, you are a person who has hemodynamically related confusion, you have hyperglycemia because you develop an insulin resistance in someone who has an infection. You get hyponatremia. Why would pneumonia give you hyponatremia? Because pneumonia is one of the many causes of SIADH. It's one of the many causes of SIADH. So a person who has severe pneumonia can get SIADH. What do we mean by severe? Hypotension, shortness of breath, shortness of breath, hypotension, confusion, shortness of breath, hypotension, confusion, shortness of breath, hypotension, confusion means you're not getting enough perfusion. And shortness of breath, hypotension, confusion means you're not getting enough perfusion. Pain, shortness of breath, hypotension, confusion means you're not getting enough perfusion. Not getting enough perfusion. I have no illusion. You need to be in a bed before you become dead. So therefore, this is what we mean by severe in terms of pneumonia. Now, it is true that people who have chronic heart disease, lung disease, liver disease, cancer, people who have chronic heart, lung, liver, kidney, cancer disease, HIV positive people, people who are on steroids, and people who have no spleen. It is true that people who have heart, lung, liver, kidney, cancer disease have no spleen, that this is a risk factor for doing badly. It is true that people who are above the age of 65 are at risk for doing badly. But having hypotension, confusion, tachycardia, a high white count, a high white count, a high fever, a high white count, a high fever, that's not a risk for doing badly. That is doing badly. It's true that chronic heart, lung, liver, kidney, cancer, HIV, steroids, no spleen, cirrhotic, nephrotic is a risk for doing badly. But being so hypotensive and short of breath, that's not a risk for doing badly. That is doing badly. In other words, from the point of view of being alive next week, it's better to be 79 and not hypotensive than to be 29 and be hypotensive, confused, tachycardia, have a high fever and a high white count. What do we mean by severe? Ready? Pneumonia. Let's change some thoughts. You can't use symptoms to tell you etiology. We know strep pneumonia is the most common, but forget about that. Oh, smoker have H flu and crap. You can have strep pneumonia, Haemophilus, Klebsiella, staph pneumonia. First of all, we don't get a diagnosis often. Second of all, the major issue is not the organism, because you don't have it today. The major issue is treat, don't treat. Admit, not admit. How do you determine admission? Severe. What do we mean by severe? These are risk factors for doing badly, but these things are doing badly. Fever, white count, hypotension. Why do you get hyponatremia? SIADH. SIADH. The last issue in terms of pneumonias is going to be who should get the vaccine. Who should be vaccinated? Vaccinated. And the answer is, it turns out, you see these? All of these things here are indications for the vaccine. Wow, I can't believe it. You mean half the indications for admission are the same thing as the indications for vaccination? Yeah, why memorize it twice? Why memorize it twice? And by the way, most of these are also the indication for flu vaccine, except the flu is above 50. The flu is yearly. This is once above 65. Then the flu goes to healthcare workers. Pneumococcus, we don't give that to our patients. We are not the reservoir of pneumococcus. It's kind of like relationships. Look, I understand that I was wrong in that about the relationship, and you can blame that on me. But this is not my fault. I did not give you pneumococcus. I understand you can blame the influenza on me. I understand you can do that, but you cannot blame the pneumococcus on me. Where is the environmental reservoir of pneumococcus? It's the most common cause of sinusitis, otitis, the most common cause of community-acquired meningitis and pneumonia. Where's the environmental reservoir? The answer is, I don't know. A child comes to me with hands full, saying, "What is the grass?" How can I answer the child? I do not know any more than he. A child comes to me with hands full of sputum, saying, "What is the pneumococcus, and where is the environmental reservoir?" How can I answer the child? I do not know any more than he. What is the difference between you and me, besides male pattern hair loss? The answer is, you have superficial ignorance. You don't know, and you think somewhere someone knows. And you have superficial ignorance. Whereas me, I am a specialist, and I have deep ignorance. I don't know, and nobody knows. And that's the point of education, to deepen your ignorance. Where does pneumococcus come from? I don't know. But we do know that healthcare workers don't transmit it, and it's more common above 65. Now, the other issues about pneumonia are going to be, how do you know that it is time to test someone for the cold agglutinins of mycoplasma? How do you know that it is time to test someone for the urine antigen of Legionella? How do you know that it is time to test someone with bronchoalveolar lavage for pneumocystis? How do you know that it is viral pneumonia? How do you know that someone has Coxiella burnetii? Well, what do these all have in common? What they all have in common is that all these people, generally speaking, all of them have a dry cough. What do these have in common? Well, generally speaking, these all have in common a chest X-ray that has bilateral disease, often interstitial infiltrates. That's what they have in common. What do they have in common? They have in common the fact that they're all called atypical pneumonias. What do they mean by atypical? It means that the Gram stain is negative and the regular bacterial culture is negative. Now you know why atypical is a bad word. There are more atypicals than there are typical. So that's why atypical is a bad word. Why should I test you initially with cold agglutinins for mycoplasma and mycoplasma serology? Why not get the urine antigen? I'm a what? Urine antigen. I'm a what? What'd you call me? Oh, they get an antigen in their urine. Welcome to infectious diseases. Not only do you have to know to test for cold agglutinins for mycoplasma, bronchoalveolar lavage for pneumocystis, but you have to say, what is it that's going to be in the case that tells you it's time to get the cold agglutinins? And in this case, it's going to be a young, because if you think about it, Legionella is older people, healthy, because if you think about it, Legionella is going to be people who are cigar-smoking older guys, young and healthy people. It's not a person, for instance, who's HIV positive, who's got less than 200 CD4 count. Young, healthy people in the community. In other words, it's not someone who's been having unprotected contact with a small furry animal. Coxiella. What on earth should make me get a Coxiella serology? Why should I get that Coxiella serology? Well, have you had unprotected close contact with a sheep placenta? The sheep placenta will give you the Coxiella. Well, here, mycoplasma, young and healthy person, no animal exposure history, no HIV, no cigar smoking older guys. Healthy person, get me a cold agglutinin and a serology for mycoplasma. What's the therapy? Macrolide. What's the therapy? Quinolone, doxycycline. Macrolide, quinolone, doxycycline. Macrolide, quinolone, doxycycline. Coxiella, macrolide, quinolone, doxycycline. Legionella. What's going to make me get that urine antigen? Don't say exposure to air conditioning. Everybody's exposed to air conditioning. But Legionella is an older cigar-smoking guy who's got some GI problems and some CNS problems. He's got some GI problems and he's got some CNS problems. He's got some GI problems and he's got some CNS problems. Older cigar-smoking people with diarrhea. Makes me get the Legionella urine antigen. What will tell me to get that Legionella culture? Specialized culture medium, charcoal yeast extract. Older guys with GI and CNS problems, Legionella, outbreaks, epidemics, epidemics. Now, a guy with AIDS comes to the emergency department. A guy with AIDS comes to the emergency department with shortness of breath. He comes to the emergency department with shortness of breath. He comes with hypoxia, PO2 of 65. You give him oxygen. What's the next best step in the management of this patient? Oxygen and trimethoprim sulfamethoxazole. Oxygen and trimethoprim sulfamethoxazole. He's got a PO2 of 65. He's got a PO2 of 65. Oxygen and trimethoprim sulfamethoxazole. Now, what is the next best step? AIDS, low T cells, shortness of breath. AIDS, low T cells, shortness of breath. AIDS, low T cells, shortness of breath. Give him some Bactrim. What do you do next in the management of this patient? And the answer is add steroids. You add steroids for when it's severe pneumocystis. Now the question is, what do you mean by severe? What do you mean by severe? Severe in terms of pneumocystis means a PO2 less than 70 or an AA gradient greater than 65. A PO2 less than 70 or an alveolar arterial gradient greater than 65. A PO2 less than 70 or an AA gradient greater than 65, you add steroids. So you add steroids when it's severe. You add steroids when it's severe. And severe means an AA gradient greater than 35 or a PO2 less than 70. Now, what's the most common adverse effect of trimethoprim sulfamethoxazole? A rash. A rash is the most common adverse effect. Now here's where people get lost around the bend. If you have a rash to Bactrim, you go to IV pentamidine, but that's only for active disease. If it is for prophylaxis, you use dapsone or atovaquone. Dapsone or atovaquone for prophylaxis. IV pentamidine for treatment. IV pentamidine for treatment. So therefore, Bactrim, rash, IV pentamidine for treatment. Bactrim, rash, dapsone or atovaquone for prophylaxis. There is no therapy for the viral meningitis, viral pneumonia, and there is no specific treatment, and there is no specific test. Coxiella, animal exposure, get a serology for Coxiella, and give doxycycline macrolide. Mycoplasma, young and healthy person. Cold agglutinins, best initial test, serology the most accurate. Macrolide, quinolone. Legionella, older cigar smoking guys with diarrhea and confusion. Urine antigen, most accurate culture. Macrolide or quinolone. Pneumocystis, a guy with AIDS and low T cells. Start Bactrim. Add steroids if it's severe. Severe means PO2 less than 70 or AA greater than 35. Coxiella, animal exposure. Let's take a look at some x-rays and some other slides for our lung infections. What we see here is the single most important slide we can, a normal chest x-ray. Now you see there's a very good lung inspiration. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 ribs of inhalation. That's good. Normal inhalations could go down to 11 ribs. These are, by the way, breasts. Those are normal as long as this is not a man. The heart shadow here, this is normal. That's the left ventricle. The right ventricle here is anteriorly. See this thing? That's the pulmonary artery. There's a pulmonary artery. There's a pulmonary artery. There's my carina. My Karina. Sounds like a good girl's name, huh? Oh, this is my sister, Karina. Oh, this is my wife, Chlamydia. But here it is. Here's Karina. Okay, this is a pulmonary artery, clavicle, clavicle. Okay, and this is a normal chest x-ray because the lung fields are clear and dark. These thin white lines are blood vessels going out here on end, and that is normal. The most important x-ray is a normal x-ray. Oh, I'm obsessing. Here is a wall of the cavity. There's air in the center, and this is a wall of the cavity. This white stuff here, this is what's called post-obstructive pneumonia. It is normal that if you have a big mass lesion there, you should have some post-obstructive pneumonia or atelectasis. Atelectasis and post-obstructive pneumonia. Wall, air, and we have infiltrate distal to the cavity. What is the single most accurate test for this lung abscess? Is it a chest x-ray, a chest CT, a chest MRI, or sputum culture, or a biopsy? And the answer is the most accurate is always a biopsy. This is the wall of the cavity, the air in the cavity, and the post-obstructive pneumonia. Wall, air, wall, lung abscess. Our next slide, community-acquired pneumonia, again showing a lobar infiltrate. Now, the most accurate test for this is a sputum stain, the sputum culture. However, remember, although we're saying it's strep pneumonia, pneumonia from strep pneumoniae, we don't know that until it grows in culture 2 or 3 days later. Remember that you do not have the results of culture at the time you're making the treatment decision. So therefore, the treatment decision, admit, not admit, the empiric therapy, is not based on the organism, it's based on the severity of the disease. Now, these are interstitial infiltrates, okay? These thin light lines here, these thin light lines are interstitial infiltrates. They're not sucking in the air, it's bilateral and interstitial, bilateral and interstitial. This one x-ray would be the same pneumonia x-ray that you would see for mycoplasma, Legionella, chlamydia, viruses, pneumocystis, Coxiella, viruses, chlamydia, mycoplasma, pneumocystis. All of those diseases could have this x-ray, interstitial infiltrates. Now, our treatment decisions here. Our treatment decisions are going to be based not on what the organism is. You see here it says outpatient macrolide or a new fluoroquinolone. You see, the old fluoroquinolone, ciprofloxacin, did not cover pneumococcus. Ciprofloxacin is an excellent gram-negative drug. E. coli, Klebsiella, Enterobacter, Citrobacter, but ciprofloxacin is not a pneumococcal drug. Whereas these other fluoroquinolones, levo, these are excellent pneumococcal drugs. But the main issue is not on whether the organism is, but on inpatient and outpatient. Now, community-acquired pneumonia means that it's the organism you walk in with. This thing about hospital-acquired pneumonia is defined as starting in the hospital after you've been there for 2 or 3 days. It also means that the more you're in the hospital, the longer you're there, the more often you're there with a ventilator-associated pneumonia, the more likely you are to have a gram-negative organism such as E. coli, Pseudomonas, Klebsiella, Enterobacter, Citrobacter, Morganella, E. coli, Klebsiella. So therefore, hospital-acquired infections are gram-negative. Community-acquired pneumonias are from people who have pneumococcus in the community. All right, our next subject is tuberculosis. Now, tuberculosis, we could have put tuberculosis in with all the other respiratory infections. Tuberculosis, after all, fever, cough, sputum, fever, cough, sputum. The reason that we're doing TB separately is because the treatment, but mostly because of the PPD. The first part is this. You're going to have a question say, you have an immigrant prisoner. It's going to be an immigrant prisoner who's an HIV positive, homeless alcoholic healthcare worker. A homeless alcoholic healthcare worker who's a prisoner of a nursing home. A homeless alcoholic healthcare worker, prisoner of a nursing home, recent immigrant who comes with a fever, cough, and sputum. But the difference between this fever, cough, and sputum is that this fever, cough, and sputum is going to be chronic, long-term, months. How do you know that's not an abscess? And the answer is abscesses smell like fermented donkey diarrhea. Abscesses smell like something's rotting. Oh my God, is that part of your body parts you're smelling here? Fever, cough, and sputum. TB doesn't have a smell to it. The best initial test for all respiratory infections is always a chest X-ray. The chest X-ray shows an apical infiltrate, the apex infiltrate, because TB likes the air that's at the apex of the lungs. Now here's the next big question. When you have a person in a risk group with a respiratory infection who's got an apical infiltrate, what is the next best step in management? When you have a person who's in a risk group who has a respiratory infection with an abnormal X-ray, what is the next best step in management? What is the next best step in management when you have a person in a risk group with a respiratory infection with an abnormal chest X-ray? Is it a PPD? Sputum stain and culture? Start empiric therapy. And the answer is sputum stain and culture. Sputum stain and culture. Sputum acid fast bacilli stain and sputum acid fast bacillus culture. I didn't say you had to wait for results of culture, which can take 6 weeks, but sputum acid fast stain and culture should be sent next. Why not empiric therapy? Because if you do empiric therapy, you're going to destroy the results of your culture. Why not plant a PPD? And here's the first thing. You ready? The PPD is not for acutely symptomatic patients. The PPD is to screen. And as all screening tests, by definition, screening is in asymptomatic people. You screen asymptomatic people. By definition, screening is at asymptomatic people. You do sputum stains and culture. And if the sputum stain is positive, then you start empiric therapy. When you have an acutely symptomatic patient and the chest X-ray is done, you do not have to wait for the results of of culture. Don't start empiric therapy. It'll destroy the sensitivity of your culture. On the other hand, you don't have to wait for the results of the culture. You must obtain the samples, and if the stain is positive, start the empiric therapy. Now let's look at that empiric therapy. The empiric therapy is isoniazid, rifampin, pyrazinamide, and ethambutol. We're going to use 4 drugs for the first 2 months. 4 drugs for the first 2 months. 4 drugs for the first 2 months, or until we have the result of our culture and sensitivity. 4 drugs, INH, rifampin, pyrazinamide, ethambutol for the first 2 months. Now, which of these drugs is liver toxic? Which is hepatotoxic? The answer is all of them. Which of these is hepatotoxic? The answer is all of these are hepatotoxic. Which of these causes neurological problems? Which of these can cause neurological problems? And the answer is NeuroH. Neurological problems. Which of these cause neurological problems? The answer is all of them. Nope, only INH. They all can cause liver, but only isoniazid can cause neurological problems. Isoniazid is associated with increased urinary loss of pyridoxine, vitamin B6. That urinary loss of vitamin B6 gives the numbness and the tingling. I am numb and tingling. I feel so numb and tingly when you're near. Are you in love? Maybe, but I think it's just the INH. So, neurological problems, isoniazid. Which of these drugs gives red secretions, red tears, red urine, red saliva? Time to wear those red contact lenses. Time to break out the orange underwear. Which of them gives you red secretions and red body fluids? And the answer is Rifampin. Rifampin causes a benign orange-red color of bodily fluids. Which of these causes eye problems? Optic neuritis. Optic neuritis. Which of these causes eye problems? Optic neuritis. Eye problems is with the ethambutol. Eye problems is with the ethambutol. Eye problems is with the ethambutol. Optic neuritis. Eye problems is with the ethambutol. With the optic neuritis. Eye problems, ethambutol. Optic neuritis. Now, pyrazinamide, must have a tragic flaw, right? Can't be perfect. It's got to have a problem, right? And pyrazinamide causes hyperuricemia. Increased uric acid. So here's the story. You go on 4 drugs for the first 2 months. Then you follow it with INH, isoniazid, and rifampin for a total of 4 months. And that means the standard length of therapy for tuberculosis is 6 months is the standard length of therapy for tuberculosis. 6 months is the standard length. A guy is on 4 TB drugs for the last 4 weeks. He's on 4 drugs for the last 4 weeks, and he develops a hyperuricemia. He's on 4 drugs for the last 4 weeks, and he develops a hyperuricemia. What is the next best step in the management of this patient? He's developed a hyperuricemia over the last month. What you want to do about it? Huh? ¿Qué tú quieres ahora, papito? And the answer is, I will do nothing. Because you're gonna stop the drug in a few weeks anyway. The pyrazinamide is only on for the first 2 months. As a matter of fact, the whole point of PZA is that pyrazinamide takes it from 9 months of therapy and reduces it down to 6 months of therapy. It reduces it from 9 months down to 6 months. From 9 months down to 6 months. It reduces it from 9 months of therapy down to 6 months of therapy. So what's the whole point? First of all, if you stop the pyrazinamide, you got to extend the length of therapy. Second, it's an asymptomatic hyperuricemia. So what? Don't treat asymptomatic hyperuricemias. Don't treat asymptomatic hyperuricemias. Don't treat asymptomatic red things. If you have optic neuritis, you got to stop the ethambutol. Optic neuritis, stop the ethambutol. Neurological problems, give pyridoxine. Neurological problems, pyridoxine. 4 drugs for the first 2 months, 2 drugs for the next 4 months equals 6 months total. Equals 6 months total. Equals 6 months total. Who goes to greater than 6 months of therapy? Who gets greater than 6 months? Bone infection, greater than 6 months. TB osteomyelitis, brain infections, TB meningitis, miliary disease, bone disease, and pregnant. Who gets greater than 6 months of therapy? Bone osteo, brain meningitis, miliary, and pregnant. Greater than 6 months? Bone and brain and miliary pregnant. Greater than 6 months? Bone and brain and miliary pregnant. 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 Greater than 6 months of therapy. Greater than 6 months of therapy. Who gets steroids? Who gets steroids? Ha 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 ha! Do you remember from the Paleozoic of an hour ago? Ha ha ha! Ancient history. Are you demented? Can you remember 3 objects in 5 minutes? Which form of TB gets steroids? TB meningitis and TB pericarditis. Tuberculosis pericarditis. So your pericardium doesn't become shriveled up and clog off your heart. Oh. TB meningitis, and TB pericarditis. Who gets greater than 6 months? Bone and brain and newly pregnant. Which of these drugs cause hepatotoxicity, liver toxicity? All of them. I and neuro H with the neurological problems. Red things with redfampin. Pyrazinamide, asymptomatic hyperuricemia. Don't treat asymptomatic hyperuricemias. Eye problems with the ethambutol. PPD. PPD. PPD is the hardest single test in all of medicine. Ready? Prepare to abandon everything you have learned about the PPD. Your mind has been captured by the past. You will be destroyed unless you can abandon your previous beliefs about PPD. Now I'm going to say the truth to you. Do you believe? I'm going to tell you the truth, and I am a witness unto the truth of PPDs. If you persist in your beliefs, you will be damned. You must unlearn what you have learned. So therefore, PPDs are to screen asymptomatic people, but not everybody. It's not a general screening test. You ready? The PPD is only to screen risk groups. The PPD is to screen risk groups. The PPD is to screen risk groups. The PPD is not a general screening test. The PPD is not a general screening test. Now hear this. School children in New York City are not supposed to get a PPD. Truck drivers in Wisconsin not supposed to get a PPD. Ford Motor Plant guys in Detroit not supposed to get a PPD. School teachers not a PPD. Office workers not a PPD. Who should be screened? Immigrants, prisoners, HIV, homeless, alcoholic, nursing home people. Next thing. What's positive? Generally greater than 10 millimeters is positive. Who's positive at greater than 5 millimeters? Close contacts, HIV positive people, people who are on steroids, usually they're organ transplant recipients who are on steroids. Everybody else 10 millimeters. Well, what's this 15 millimeter group? 15 millimeters is a little bit weird. They're for people who should never have been tested. I don't get that. You mean what's positive for people who shouldn't have been tested? Uh-huh. It means that if you shouldn't have been tested and you get a 15 millimeter, you should still be treated. 5 millimeters, close contacts, HIV, steroid users, abnormal old x-rays. 10 millimeters is all these other people. What is a treatment for a positive PPD? Well, you know what? A PPD that's positive confers about a 10% lifetime risk of developing tuberculosis. If you give a person for their positive PPD, you give them INH alone for 9 months. INH alone for 9 months. When you give them INH alone for 9 months, that will reduce that by a 90% reduction. That will give people a 90% reduction. So you take that 10% lifetime risk and make it a 1%. Now, most of that 10% lifetime risk is in the first 2 years after you've converted. Here's another big thing. If you've never been PPD tested before, you should be getting, if your first one is negative, you should get a second test in 1 to 2 weeks. You should get a second test in 1 to 2 weeks. If your first test is negative, you should get a second test in 1 to 2 weeks. So a first test is negative means a second test in 1 to 2 weeks after the first test, 1 to 2 weeks later. So if you have a first test that's negative, you should get a second test in 1 to 2 weeks. Okay? INH alone for 9 months gives you a 90% reduction, that's 10% lifetime risk. 5 millimeters for HIV positive, 5 millimeters for close contacts. Notice how complex this is? 3 cutoffs. 10 millimeters is for the general population of risk groups, these risk groups. 15 millimeters is people who shouldn't have been tested. INH alone for 9 months. If your first test is negative, you should get a second test to make sure the first one was a true negative. Next thing, if your PPD is positive, when should you get a second test? Okay, closing my face. Close, ready? Show all my pimples now. If your first test is positive, when should you get the second test? And the answer is never. If the first test or any test for a PPD is positive, when do you get a repeat? The answer is never. Okay, back up now, back up now. Now, the next thing is this. Who gets annual screening chest x-rays? Do you know, you see the way my head is going like this? Who should get annual screening chest x-rays? Nobody should get annual screening chest x-rays. But I thought, I thought, I thought I saw a putty tat. Yeah, well, but the whole point is, there's no point in doing second tests if the first one's positive. Once the PPD is positive, that's it. You get INH for 9 months and you're done. Last thing, what is the effect of BCG on these recommendations? If a person has had a BCG, bacille camètre guaron, what do you change in these recommendations? And the answer is nothing. If you had a BCG, you pretend that BCG doesn't exist. Now, this is going to be a big problem for a number of people who are out there in video land, out there in DVD land, out there in tapey land, is that you're going to go, oh no, because I was told that with a BCG you test with a PPD to see when it's time to revaccinate. Well, I would like to point out what the name of the test is that we're studying for, and it's called USMLE. And on USMLE, it means we don't care about BCG. BCG is not a US test, not a US, treatment. BCG does not exist here. We don't give anybody BCG. It means that if you had BCG, we ignore it. And the reason is that tuberculosis is at the lowest reported incidence in the history of the country. Even until 1941, in New York City, 1 generation ago, tuberculosis was the most common cause of death in the United States and in New York City. Even in New York City, the most common cause of death. Now, the rates of TB deaths have been dropping steadily since the beginning of the century. And then around 1950, they took a precipitous drop down, and now, in the year 2007, we are at the lowest reported incidence in the history of the country. Now, over here in the 1950s was the invention of TB meds. That's how that happened. But right now, we are at 15,000 cases a year in the entire United States, 10,000 of which occur in what we used to call immigrants, but we now like to call them imported people. Are you an immigrant? No, I'm an import. Special, like a Mercedes or BMW. So the whole thing is, we don't do BCG. We test risk groups. How is it that the incidence of TB was dropping before the invention of TB meds? And the answer is public health, TB lockup. If you have tuberculosis, you want to cough around on the street, you can't do that. Now, in 1895, the modern concept of the modern health department was invented in New York City, a guy named Herman Biggs. And our friend Herman Biggs invented public health, basically modern public health. Modern public health, in terms of cities and municipalities, he invented TB lockup. He said, you got tuberculosis, you can't run around on the street. You want to cough up sputum with tuberculosis? We can take you on an island in the East River, lock you up. Isolation. Herman Biggs said this: the death rate can be purchased. Every city, every municipality in the country can determine its own death rate based on how much money it's willing to spend. And the same is true. The death rate can be purchased. So he invented TB lockup, which to this day is still in effect. You have a patient in the question, and the patient says, I'm going to cough up sputum, doesn't want to take medications. You can't force him to take meds, but you can incarcerate him. And then the patient says, you've got me locked up here, doc. I have the right to a lawyer. I have the right to representation. You go, oh, no, you don't. I have the right to see a judge. I have the right to this. Oh, no, you don't. Why? You're incarcerating me here. I have the right to a lawyer. Oh, no. You see, you don't. Because you see, you're not arrested. Because I'm not a policeman. I'm a doctor. So you don't have the right to anything. But you do have the right to take your tuberculosis medications. TB lockup. It's a wonderful thing. Ready? You see this? You see the BCG? You ready? Watch. Watch. 1, 2. Doesn't exist. You may think that your BCG means that your PPD is positive and you don't get to eat your INH. Incorrect. It has happened twice in the last 10 years that immigrant healthcare workers came to the United States and had PPDs that were above 10 millimeters. In both cases, they did not take their isoniazid because they said, I am from an endemic area in which I had BCG as well as being everybody is exposed. The two healthcare workers failed to take their INH as prescribed. In separate cities in the United States over the next year working in the hospital, they proceeded to expose hundreds and thousands of patients over the course of the year. Many of these patients became PPD positive when the healthcare workers developed their TB. And several patients, including several neonates exposed to tuberculosis, died. So we don't care about BCG. Your PPD is positive, greater than 10 millimeters, you eat INH for 9 months, and that's the way it is. Let's look at some slides for tuberculosis. Pulmonary tuberculosis. You will see here that what we have apical infiltrates. What is the next best step in the management of this patient? The answer is PPD, sputum stain, sputum culture. And the answer is sputum stain and sputum culture is the next best step in this person with the apical infiltrates. Apical infiltrate, sputum stain and culture. When the sputum stain and culture is positive, or sputum stain is positive, isolate the patient. Actually, isolation can happen even before then, but it certainly should happen by the time their stain is positive. PPD testing is absolutely the wrong thing to do. Let's look up at the board. If your PPD is positive, you get a chest x-ray. And if the chest x-ray is negative, you get to eat INH for 9 months. If your chest x-ray is positive, you check sputum to see whether the person needs 4 drugs. Now, this person already has a positive chest x-ray. So we're already going to check the sputum. So what's the point in doing a PPD? If the PPD is positive, you're going to get a chest x-ray. If the chest x-ray is abnormal, you're going to check a sputum. This person has a positive chest x-ray. Check the sputum. Next thing, TB pericardium, pericarditis. You see this white stuff around the heart? That is calcification and fibrosis around the pericardium. This is a person who didn't get the steroids that he should have gotten. TB pericarditis. You're going to have to strip that pericardium off. Acid-fast bacilli. You see these red snappers in here? You see this stuff? This is a Ziehl-Neelsen or acid-fast stain, and this is basically the stain for tuberculosis. Once the stain is positive, if they haven't been put on isolation, isolate them. 4 TB drugs, INH, rifampin, PZA, and ethamitol for 2 months. 4 drugs for the first 2 months, then 2 drugs, INH and rifampin, for the next 4 months to make 6 months total. This is a PPD. It's not the amount of redness, it's the amount of induration. It's got to be raised up, greater than 10 millimeters, raised up. Induration is what matters. If the PPD is positive, get a chest x-ray. What is the effect of BCG on this recommendation? The answer is no effect of BCG. 5 millimeters, close contacts. How close does close contact have to be? Are you considered a close contact of your patients? The answer is no. You are not a close contact of your patients. We define a close contact, it's something like this. 4 hours a day for a week. Are you spending 4 hours a day with your patient? I don't think so. 10 millimeters is the other risk groups. A homeless immigrant healthcare worker is a prisoner of a nursing home. And 15 millimeters is for those who should not have been tested in the first place. PPD, a very difficult test. PPD is as complex as anything in all of medicine. PPD test. Did you know that the PPD is the longest continuously used test in all of medicine? It has been around for over 120 years. It has been there since Robert Koch announced to the World Tuberculosis Conference that he had found the cure for tuberculosis. And he ruined his career at the end of his life, had 2 Nobel Prizes for tuberculosis, for being the first person to describe the TB bacillus, and for describing anthrax, which destroyed cattle throughout Europe and the world at that time. And the foremost scientist of his time, Robert Koch, announced to the world's media at the Berlin AIDS conference, I found the cure for tuberculosis. It is the PPD. And they said, how do you know it's a cure? And he says, look at all that skin test reactivity. He thought it was a vaccine, and he screwed it up too. The PPD is the single hardest test in all of medicine. The single hardest and the longest continuously used. Older than the X-ray, older than the EKG, older than blood testing is the PPD. It confers a 10% lifetime risk. You get INH for 9 months, which reduces that to 1%. Forget about BCG and test risk groups. Test risk groups. Isn't it wonderful that we have the opportunity to master in a very short amount of time what would take so long, so long? Why, I can feel the intelligence dripping off of you right now. I feel like it's fantastic. You don't even need me now. Go out and cure someone right now. Poof.